we're delighted to have Andrew Klein with us. Andrew's been our first guest speaker, which was extremely interesting, and it really set us up for deciding, yes, we wanted a lot more guest speakers. And so it's been an exciting year with guest speakers, and we've brought Andrew back again. Andrew's going to tell us about what he does, to do with Royal Papworth, to do with B12, to do with iron deficiency, and also explain a little bit about Club B12. So over to you, Andrew.
Thank you very much for the invitation, and hello, good evening to everybody. So my name is Andrew Klein. I'm an anaesthetist. So the first question is always, what's an anaesthetist doing iron and B12 for? So really, I've been doing research into iron deficiency for about 15 years now. Started in patients who are having surgery at Papworth Hospital, which is a heart hospital in Cambridge. So, and then it turned from patients having surgery and after surgery to patients not having surgery. And of course, iron deficiency affects many people. And then really we discovered that iron and B12 deficiency go hand in hand, and they're often intertwined, and really B12 deficiency is at the heart of this along with iron. So many of my patients present with iron deficiency but actually have B12 deficiency, or present with B12 deficiency and actually have iron deficiency as well. So I'll talk a little bit about the overlap between the two, and I'll talk a little bit about Club B12, which is, as I said, is a group of doctors, non-doctors, pharmacists, hospital doctors, geneticists, biochemists, patients and patient organizations. And we meet every 2 weeks and we talk about loads and loads and loads, 2 hours talking just about B12, which might sound mind-blowing to you, but it's probably good to know that a bunch of doctors from all around the world are talking about B12 every 2 weeks for 2 hours and looking at all the latest research and all the latest studies. And also the B12 Alliance, which is a group of all the charities, the patient groups that are working together to spread the word about B12 to patients and people around the UK and around the world. So hopefully I'll talk a little bit about that. And I'm going to illustrate my talk with one of my patients. I've got over 2,000 patients now who I've looked after with B12 and iron deficiency. And she's a lady who's given permission for me to illustrate her story. And she's a midwife in the region, so that's in the east of England. And I just want to acknowledge the people that have sort of helped us along the way. So I've had various research grants from the NIHR, which is the National Institute for Health Research in the United Kingdom, and they've given money to Papworth for research that I do. And also Pharmacosmos, who's a company that makes intravenous iron. They've also helped our research and paid for us to have some free iron to give to patients who are involved in our research studies. And actually, it's really good that doctors and researchers partner with industry, because they can then provide the findings about their drugs. They have lots and lots of data so that we can use that to help us understand how drugs work. So Pharmacosmos have paid for various research studies as well. And then my biggest conflict of interest, if you like, is I run a private clinic for iron and B12 deficiency in Cambridge, and I see about 10 or 20 patients a week with B12 and iron deficiency, do blood tests on them, give them intravenous iron and start them on B12 injections, and nearly always teach them to self-inject. So 2,000 patients I have who are self-injecting with B12 at home, but there's probably hundreds of thousands around the UK that are doing that. So I've seen a small proportion of all the patients in the UK who are self-injecting with B12. And then, as I said, I'm a member of Club B12, which is this group of doctors and researchers and pharmacists who all talk about nothing but B12. So I'm going to start by talking about this case report. This is a 30-year-old lady who works as a midwife in the east of England. And she came to me back in 2018, first of all, and she had classic iron deficiency anemia. So anemia is when you don't have enough red blood cells. So that's literally the concentration of red blood cells are reduced. So she had a low concentration of red blood cells, where her hemoglobin was 96 instead of 120. So she had about a 20-25% reduction in the concentration of red cells. So that's anemia. But she also had iron deficiency, which was a very low ferritin. So she had a ferritin which was very low when she came to me first, as well as the anemia. So the first time I saw her, I gave her an iron infusion and she got better. And then she came back again 5 years later with similar symptoms to how she had originally presented. And when she came back to me, she complained and she said she was tired all the time. She had trouble concentrating and trouble remembering things and felt she was always in a cloud. So we often call that brain fog. She had restless legs where her legs were kicking in bed and she felt it woke her up. She had cold hands and feet all the time. She felt short of breath when she was doing anything at all, really, even just walking upstairs. Her hair was falling out, which is called alopecia. She was unable to work long night shifts because of exhaustion and brain fog. So it was affecting her work as a midwife. So when I examined her, there was nothing really to find except that she was quite pale. And we did the usual blood tests, and her ferritin was 38. And the definition of iron deficiency is ferritin less than 30. So it's a little bit higher than we often see with a ferritin. But we know that patients actually get symptoms of iron deficiency when their ferritin's less than 50. Now, the NHS ranges will say ferritin less than 10 is iron deficiency. But that's just not true. That's looking at sort of a minimum range, where actually what we're looking at is the optimal range. And we know that patients get symptoms when their ferritin is less than 50, and it's defined as severe iron deficiency when the ferritin is less than 30. But what was interesting is her transferrin saturation was less than 20%, which confirms the diagnosis of severe iron deficiency. So when there's a doubt about the ferritin, we can also do what's called transferrin saturation, which is iron panel. So that's an extra test we can look at. And if the transfer saturation is less than 20%, then it's absolutely nailed on iron deficiency. So it's always a useful investigation to do on top of the ferritin. And she also had a low hemoglobin. So her count, her red blood cell was reduced. So she had iron deficiency and anemia. And again, I gave her an intravenous iron infusion. So that was her second one, 5 years after her first one. And I used Monofer, which is ferric derisimoultose, and the dose of that is 20 milligrams per kilogram. So an iron infusion is very safe. It's given over 30 minutes into a drip in the arm. The chance of a serious reaction to an iron infusion is 1 in 200,000. So it's very, very, very rare. It used to be much more common 10 or 20 years ago, and it got a bad press, iron infusions. But since then, they've refined the product and they've bioengineered it, which means they've changed the chemical structure so the body doesn't recognize it. So iron infusions are much safer than they were 10 or 20 years ago because of this bioengineering technique. Now, that's made it much safer, but it's also made it much more expensive. So iron infusions are expensive. And that's why the NHS doesn't want to do them, because they're really very expensive. So I gave her an iron infusion. And 6 months later, she was feeling a bit better. So she said she sort of felt 50% better. And she came back to me. She said she still has fatigue and brain fog. So whereas the first time I'd seen her 5 years previously, when she had the iron infusion, she was all better. But this time she was a bit better, but she had developed pins and needles and tingling in her fingers and hands, and tinnitus, which is ringing in your ears. And sometimes people describe that as a whooshing in their ears. And she had also developed a sore, swollen tongue with ridges on it, which is sometimes called geographical tongue. So she wasn't happy because she wasn't feeling better after the iron infusion. And she was still anemic. So her hemoglobin was still lower than the 120 we would expect. It was 112. And her B12 had gone from 324, which was okay, to 208. And I class B12 anytime less than 300 as low. So you start to get symptoms when B12 is less than 300, and less than 200, you get bad symptoms. So 208, it's not surprised that she was developing neurological symptoms. So pins and needles, tingling in her hands, and still having brain fog and fatigue. Those are the neurological symptoms, and the tinnitus. And she also had the sore tongue, which is classic of B12 deficiency. And I did another test, which is called an MMA. And that's recommended by NICE as part of the new NICE guidelines, that if someone's B12 is marginal, so a bit low, then you can do an MMA, which is called methylmalonic acid. And that looks at long-term B12 deficiency. And if it's more than 20, that's indicative of long-term B12 deficiency. And hers was 36. So we had clinical symptoms of B12 deficiency, which I told you about, the pins and needles and the tingling and the tinnitus and a sore tongue, plus a low B12, 208, plus a high MMA. So there was no doubt with that pattern that she had B12 deficiency. So I started her on B12 injections every other day for 6 weeks. And then her neurological symptoms went away, and then the injections became less frequent and less frequent again. And I taught her to self-inject at home. And then I gave her folic acid 5 milligrams once a week to top up her folate. And that's one of the cofactors for B12 deficiency. So it's always very important when you're having B12 injections to have iron. And remember, I'd already given her the iron infusion, so her iron levels were good, plus folic acid, plus vitamin D. So 6 months after starting her on the B12 injection, she was much, much better. And she was back to work. But they weren't letting her work on the labour suite. They were asking her to work on the upstairs ward, looking after patients after they'd had their babies, basically. And her hemoglobin had come up. Her B12 was more than the 2000, which is irrelevant when you're having injections because the B12 doesn't matter because you can't have too much B12. So whatever doctors tell you, you can't have too much B12. It's not dangerous, and a B12 level of more than 2000 is irrelevant. And her ferritin was still good, her iron stores were good, and her folate was good. So really, she was in a perfect state. Nice regular B12 injections, nice folate, nice ferritin, and feeling much, much better and back to work. So why did she have B12 deficiency? What was it about this lady that made her have B12 deficiency? So B12, as hopefully you know, is only in animal products. There's no B12 if you eat a vegan diet. You have to get B12 from fish, meat, eggs, and then there's a bit in cheese and a bit in milk. And those are your sources of B12 in your diet. But if you're a vegetarian, you don't have much B12. And if you're a vegan, you don't have any B12. So you have to supplement. But not only that, you need to absorb the B12. So you might eat 10 steaks a day. But if you don't absorb the B12 from your diet, then it's just going in one end and going out the other. So this is a really nice, neat article in the British Medical Journal from 10 years ago that summarizes the clinical symptoms of B12 deficiency. So there's that tongue, glossitis, where you get swollen tongue and you can't taste properly. There's the brain fog, depression. Young people get horrible depression, anxiety, psychosis, delusions, irritability. So quite often, or very often, B12 deficiency can present just as brain fog and depression and psychosis, so mental illness. And then the neurological symptoms, which are pins and needles, tingling, numbness, fine motor control, so you can't play the piano or use a pen, decreased reflexes, you can't feel where you are. So when you stand up on one leg, you fall over when you close your eyes because you can't feel where you are. It causes all sorts of these clinical problems, and very rarely it causes macrocytosis and anemia. So it's the neurological symptoms and the brain symptoms that are much more common than anemia or macrocytosis. And if you look, this is a table that summarizes the symptoms of long COVID on the left-hand side as you're looking at it, B12 deficiency in the middle, and iron deficiency on the right. And you can see that many, many patients have the same symptoms, whether they have long COVID, B12 deficiency, or iron deficiency. So the number one most common symptom is fatigue. Nearly everyone who has B12 or iron deficiency or long COVID or post-viral fatigue has fatigue. And then the next most common is shortness of breath, palpitations, dizziness, fainting, vertigo, so feeling dizzy, not sleeping, brain fog, can't concentrate, pins and needles, numbness, tingling, joint pain, burning in your legs and feet, depression and anxiety, tinnitus, ringing in your ears, nausea, loss of appetite, bloating, abdominal pain, fainting when you stand up or feeling faint, change in taste, temperature, and then particular to B12 deficiency is this sensory loss of taste, smell, or hearing, numbness in your hands and feet, balance problems, swollen tongue. And then restless legs is really particular to iron deficiency. And pica, which is where you crave ice or fizzy drinks or coal dust or rolled up newspaper or chickpeas. I've heard all those described where you crave things. So those are the symptoms of long COVID, B12 and iron deficiency. And you can see they overlap a lot. So the symptoms are very difficult. And if you go to your GP, often they'll only discuss one symptom at a time, or they'll say that they don't understand why there's so many symptoms. And the reason is because these conditions affect so many different things, which is why they're so difficult to diagnose. So here again, symptoms of B12 deficiency that will be familiar to many of you. And the causes are anything that affects the absorption from your stomach. So it might be surgery, or it might be inflammatory bowel disease like Crohn's or ulcerative colitis, or it might be too little acid in your stomach, or it might be too much acid in your stomach, or it might be taking PPIs like omeprazole or lansoprazole that reduce the acid in your stomach, or it might be metformin that interferes with B12 absorption, or it might be drinking too much alcohol, or a stomach infection that makes your stomach not work properly, or it might be IBS where you have constipation or diarrhea all the time and you don't absorb properly, or it might be autoimmune disease, which is the true pernicious anemia where you have autoantibodies against your stomach. So any of these things that affect the absorption from the stomach are causes of B12 deficiency. So there's a lot of different causes that we need to think about and look into. So as I said to you, B12 is critically important and it's not made by plants. So plant-based foods don't have B12 in them. And there's recent estimates, recent research that shows that there's a high rate of B12 deficiency among vegetarian and vegan populations who don't eat meat or animal products, particularly in women who have periods and particularly in pregnant women. And so as we have more and more people that choose not to eat meat or fish, then we'll have more and more B12 deficiency. Now, this is very pertinent to the lady that we were describing and discussing, this midwife. Nitrous oxide is a gas that we use in anesthesia to help keep patients asleep. And it's used in surgery, in anesthetics. It's also used in dentists. It's used in aerosol spray propellants to make whipped cream and in the automotive industry to pump up tires. And it's one of the most common drugs of abuse. And people steal nitrous oxide and they put it into these little canisters that are called whippets, and they inhale it from a balloon. And when they do that, they get a short-lasting high. So I'm told it's very commonly used at parties amongst young people to get high. And it's become a very common presentation where young people use these whippets to get high, and they develop B12 deficiency because of using nitrous oxide. So we use it in obstetrics for women having children as pain relief, and then in the emergency department for people having a shoulder put back in or who break their leg, sometimes in general anesthesia. And as I said, people use it as whippets at parties to get high. And you can see a street in London with all these whippets thrown on the pavement and in the streets. So these are all people are getting high on nitrous oxide and then throw the whippets away. And the nitrous oxide stops B12 working, basically. There's a chemical reason for it here. It's quite complicated, but the thing is that nitrous oxide stops B12 working. So if you have nitrous oxide, you become B12 deficient. So this lady who was a midwife was exposed to nitrous oxide on the labor ward, and she was breathing it in as the patients were breathing it out. So she was working on a labor ward where the windows didn't open, and she was in a closed window room where women were having nitrous oxide for 6, 7, 8 hours during labor, and she was exposed to it day after day after day. So that's how she developed B12 deficiency, because she was exposed to it in the labor ward. And we need to look at MMA to find this out sometimes, because the B12 blood test can be useless. So this has been warned about as an epidemic of B12 deficiency in young people because of nitrous oxide. And they present to emergency departments not being able to walk, falling over, and it causes neuropathy in their spinal cord. And it can develop in people who have children, have nitrous oxide on the labor ward for pain relief during labor. In the mother, in the partner, the husband or the partner who's exposed to the nitrous oxide, and in the midwife who's in the room. And this finding led to a lot of labor wards in our area pulling gas and air out of it. So women couldn't have gas and air because of this anxiety about nitrous oxide in the labor ward. So suddenly all these labor wards around the country stopped using nitrous oxide. And of course, then women were in pain when they're having babies. So that's not good either. So they've actually developed scavenging where they can scavenge the nitrous oxide from the room and crack it, so break it down so that you're not exposed to it. But of course, they cost hundreds of thousands of pounds. So a lot of hospitals are having to invest in ways of cracking the nitrous oxide so that women and midwives are not exposed to it. So some of the learning points that I've talked to you about is the B12 assay, so the blood test that your GP does, may not be helpful. In fact, it can be utterly unhelpful. And it's only accurate in about 30% of people. So that means in 70% of people, the B12 assay doesn't help you. It reads as normal, but in fact, you've still got B12 deficiency. So therefore, you need to do an MMA test, which can be helpful, like it was in this lady that I told you about. And neurological symptoms includes pins and needles and tingling and brain fog. So whenever you have those symptoms, you should look for B12 deficiency. And once you develop B12 deficiency with symptoms, you can only treat it with B12 injections, and you also need to have folic acid and iron. So I'm happy to talk to you about anything that you've thought of from listening to this midwife story and about B12 deficiency and iron deficiency in general. I'll go through the chat first before people put their hands up or their thumbs up. So Hugo said, please think about some questions or comments. And Sadaf said, is the chronic prolonged exposure to nitrous oxide causing B12 deficiency? Well, we think it's about 8 or 10 hours of exposure leads to problems with methionine synthase and deficiency. So really, it's repeated exposure. So dentists, dental nurses or assistants, midwives are exposed to it all the time. And patients who have like a short 1 or 2 hour exposure in an anesthetic wouldn't get a problem. But if you have lots of anesthetics or lots of surgery, then yes, it's the recurrent exposure and maybe 8 or 10 hours in total that would do it. Does that answer your question, Sada? Yes, thanks. And then Katrina says, do you test MMA if your doctor doesn't act on low B12 levels? Well, the NICE guidelines say if your B12 is super low, then you don't need to test MMA. You've got the diagnosis. So I say if your B12 is less than 200, you don't need to test MMA. You've got B12 deficiency. That's it. End of story. Treat with B12 injections. It's the 200 to 300 or 200 to 400 where you're not sure, where the blood test doesn't help. That's when you need to test MMA because it increases the sensitivity of the blood test. So MMA is a specialist test. Most GPs don't have access to it yet. Hospitals do have access to it, but they may not want to use it. And I have access to it in my clinic. It costs about £90 through the laboratory, which is why the GPs don't want to do it because it's quite expensive. And it increases the sensitivity, so the accuracy of the blood test you do. So if you have low B12 blood test, then you don't need to have an MMA. But if you have indeterminate, so in the middle blood test, say 200 to 300 or 200 to 400, and you're not sure, then it's worth doing an MMA blood test. But unfortunately, the MMA blood test only has a 50% sensitivity, so it's still not a good blood test. So I find it improves the accuracy, but it's still not great. Now that's really disappointing because we haven't got a good blood test to diagnose B12 deficiency. So B12 blood test, rubbish. MMA blood test, better, but still not great. So sometimes you have to go on clinical suspicion. That means symptoms and maybe a normal B12 blood test and have a course of B12 injections. So the NHS definitely won't do that. They will only do it if you have a low B12 blood test. But I often give a course of injections to my patients who have normal tests to see if it works, because B12 is harmless. And if they get better, then they have B12 deficiency. And if they don't, then we were wrong. So B12 blood test, pretty poor. MMA, a bit better. And you can get it privately via Medichecks, as Elaine says on the chat. And it's a bit better than B12 on its own. So does that answer your question, Rachel? And then the next question was Zara, yes, MMA is a toxin which gradually accumulates when B12 is too low, sometimes. Zara says, can low ferritin be caused by B12 deficiency? Well, B12 deficiency is a disease of the stomach where you don't absorb B12 properly due to all those causes that I told you about. But when you don't absorb B12 properly, you also don't absorb iron properly. So many people who have B12 deficiency also have iron deficiency. So the low ferritin isn't being caused by B12, it's being caused by the disease, the stomach disease, that stops you absorbing iron and B12. And when you have a low ferritin, the B12 doesn't work. So what I found is if your ferritin is less than 50, the B12 doesn't work. So you need to have a decent ferritin, and that's why you need to take iron supplements and get your ferritin above 50 and keep it above 50. And you may need an iron infusion if the iron supplements don't work. So it's absolutely crucial. I know you talk about it probably at every meeting. The cofactors are crucial. So for B12 to work, you need a good folate, 15 to 20. You need a good iron stores, a ferritin of more than 50, and you need a good vitamin D level, 75 to 100. And if one of those three are not good, then your B12 won't work. It will wear off quickly and it won't work properly. So you've got to have good iron stores, you've got to have a good folate, and you've got to have good vitamin D for B12 deficiency. So the answer is, Zara, it's the disease of the stomach that stops you absorbing the iron, and you've got to have good iron levels for your B12 to work. Elaine says, I thought folate, methylfolate, was the better supplement to take rather than folic acid. So folic acid is B9, which increases your folate. So folate is the blood level of B9, and folic acid is the basic supplement, which is B9. But methylfolate is already methylated. So some people absorb methylfolate better than folic acid. So methylfolate, you give it a much lower dose than folic acid. So folic acid, if you've got B12 deficiency, you generally need to take a lot of it. So 5 milligrams once or twice or 3 times a week. Whereas methylfolate, because it's already methylated, it's easier to absorb and you need a lower dose. So usually only 400 micrograms every day or 3 or 4 times a week. So methylfolate is easier to absorb and in some people has less side effects and you need a lesser dose because it's easier to absorb because it's already been methylated. Does that make sense, Elaine? And then Haley says, can you take too much iron? Well, you can, but you have to take a vast amount to take too much. So really you would you'd have to get your ferritins above 700 or 800 to have a problem with too much iron. So it's pretty much difficult to have too much iron. Everyone's scared of having too much iron, but you need to take a vast amount. The problem is with oral iron is it causes stomach symptoms. So lots of people get constipated with oral iron, or they get the other way, they get diarrhea, or they get tummy pain and bloating. So lots and lots of people can't take much oral iron. So that's why they end up having an iron infusion because they can't take enough oral iron because they get constipation and diarrhea, and then their ferritin falls. So you can't really take too much oral iron except you can give yourself constipation or diarrhea. So really with oral iron, less is more. So you need to take a little bit and probably every other day. So very often the GP will give you 200 milligrams of oral iron twice a day. And in fact, that's the wrong dose. It should be 20 milligrams of oral iron every other day. So you take a small dose and then you let your tummy recover, and then a small dose 2 days later, and then let your tummy recover. So it's very important to have a recovery between each dose of oral iron. So with oral iron, less is more. A small dose every other day works much better than a big dose every day or twice a day. So you can't take too much except for the effect it has on your stomach, Haley. Emma says, I self-inject B12 3 times a week and I'm still tired. All my blood tests come back normal. Is there anything else I can do? Well, is your ferritin above 50, Emma, or 75? Is your folate 15 to 20? Is your vitamin D 75 to 100? And there are some people that if even with all those things being perfect, they still need a lot of B12. So 3 times a week, 4 times a week, even every day, and they still need B12. So there are some people that still have a lot of B12 requirement, even with all the cofactors perfect. And it sounds like, Emma, you might be in that category, someone who still needs a lot. And they might need to take a lot for a year, 2 years, 3 years. So I have people that still improve after 2 years of every other day injection. And I know people that have had every other day injections for 10 years and are still improving. So it's very frustrating. Some people improve after 3 months. Some people improve after 3 weeks, but some people can take 3 years before they improve. So it really depends on your rate of metabolism, the rate of methylation, and everyone's different, I'm afraid. So if you're still tired, I would say keep going and keep checking your bloods every 6 months for the cofactors. So I hope that's answered your question, Emma. The next question is Katrina. My question is blood or urine better for MMA? There's a lot of discussion about that at Club B12. I don't know is the answer. I only do blood MMA. In some countries in the world, they do urinary MMA instead, and they swear it's better. And I don't know. I think the sensitivity, the accuracy of MMA is still about 50% whether you do blood or urine. But in my laboratory, they don't test urine MMA. So I'm afraid I don't know the answer to that. Jill said, does private healthcare providers pay for iron infusions? The answer is, Jill, everyone except AXA. So all the private insurers, Bupa, Vitality, Aviva, Helix, WPA, they all pay for iron infusions if your ferritin is less than 50 or less than 30 if it's Bupa. But AXA are the worst in terms of paying for iron infusions. So none of my patients who have AXA will pay for it. And I'm afraid an iron infusion is expensive. It's £900. So having private health insurance can be helpful if you have got it. But if not, you're looking at £900, I'm afraid. Not cheap. That's because of this bioengineering to make the drug safe. Hugo says, is it enough to give a big dose of B12 after nitrous oxide every time rather than waiting? I don't know, Hugo. No one's ever done that study. Maybe. But I think the problem is that a big dose or a small dose is excreted after 6 hours. So the half-life, because you excrete it so fast that even a big dose would just get excreted in a big way in 6 hours. So it may not be enough to replete the B12 because it's excreted so quickly. So it may be that more frequent injections are necessary rather than a single big dose because of the chemical, it's called the pharmacokinetics, the fact that you excrete it so quickly. Fire people get B12 injections after exposure to cyanide, smoke inhalation. Yes, they do. So that's another cause where smoke inhalation stops you absorbing B12. So you can see there's so many causes that affect B12 deficiency. And because there's so many people on the call, you could probably find that many of you have a different reason each for their B12 deficiency. There's so many causes. Julia said, what is your opinion on every other day injection for long periods of time, like a couple of years? No problem, Julia. As I said, I know people that have done it for 10 years. You need what you need, and everybody needs a different amount. And I'm sure if I asked everybody in this call, you'd all be on different amounts over different time points. So, Julie, if you need every other day for 2 years, no problem. For 20 years, no problem. As long as you keep an eye on your iron and folate and vitamin D and take enough of those cofactors to keep your levels up. PC says to everyone, what do you think of homocysteine as a test for B12 deficiency? Homocysteine is a real problem because in my lab, you have to keep it refrigerated on ice and deliver it to the lab very quickly because it has to be stored and tested quickly. So I don't know about homocysteine as a finger prick test. I've never heard of that, but it would be very interesting. And we have real problems with homocysteine in our lab because of the way it degenerates in the blood test. So I only ever test MMA. So homocysteine is a problem because of transporting it to laboratories. So if it was a finger prick, that would be very, very interesting. And I'd love to see that. Homer S says, is blood volume of any consideration in clinical practice? No. I'm afraid to say that's a myth. So blood volume is regulated minute to minute, second to second by something called antidiuretic hormone. And you regulate your blood volume. So if I was to give you a liter of saline, your antidiuretic hormone would go down and you would excrete that liter of saline in a few hours in your urine. So you'd wee it out. So your blood volume makes no difference. So a liter of saline is gone in a few hours. So really, it's not about blood volume. It's about the regulation of blood volume. And when you've had COVID or a post-viral fatigue, it's your regulation, your auto-regulation that's got up the spout. And one of the reasons it's got up the spout may be B12 deficiency, which is why treating it with B12 can make your auto-regulation better. So we think that's one of the causes of B12, of long COVID, is this auto-regulation that's gone haywire. Rachel says, what about testing for active B12? Well, active B12 is a bit better than the total B12. And it's a bit disappointing. When it first came out about 5 years ago, everyone thought this was brilliant. We're now going to be able to test for active B12 and all the problem with B12 deficiency being diagnosed with total B12 would be solved. But actually, active B12 is still affected by any B12 or B9 folic acid in your diet, and it still affects for about 3 months. So the problem is if you drink oat milk with vitamin B in it, if you have Marmite on your bread, if you have multivitamins or folic acid supplements or B12 supplements or B complex supplements, anything with B in it, and they want to put B9 in flour in the UK. So when that happens, we will never be able to test for B12 again in the UK, because once you supplement with B9 in flour, you can't test for B12 or active B12. So active B12 is a bit better, but not much better. So sometimes it helps us if the B12 result is a bit indeterminate. But a lot of the labs are now offering back active B12 instead of B12 because it's a bit better, but not much difference. Hugo says blood volume was an excuse used by doctors, but bodies regulate blood content very finely. Exactly, Hugo. Blood volume is just an excuse. So active B12 a bit better, but not much better. Susan Peacock says, I'm on methotrexate. Can it have an effect on my B12? Yes, if you have rheumatoid arthritis, it's an autoimmune disease, and many arthritis conditions an autoimmune disease, and the auto antibodies attack your stomach and stop you absorbing B12. So any autoimmune disease can cause B12 deficiency, including rheumatoid arthritis. And patients with rheumatoid often get B12 deficiency. They take folic acid, which is the B9, and that stops the B12 test from being accurate. So a lot of doctors don't diagnose it because everyone gets folic acid with their methotrexate, and then you can't diagnose the B12 deficiency. So a lot of people with rheumatoid arthritis get B12 deficiency, and you says you're taking B12 injection self-administered. Good, that's probably helping. Gum Bacon says, if B12 iron deficiency is the cause of headaches, should painkillers work or not? Well, painkillers work because they go via a different pathway. So they often work on the GABA pathway or the opioid pathway or the COX, which is the cyclooxygenase pathway. So painkillers should work, but B12 causes an iron deficiency cause headaches because of you get oxygen lack in iron deficiency and neuronal brain sort of damage with B12 deficiency. And that's why you get headaches, because basically your brain is working harder than the oxygen or the B12 that you can support it. So the painkillers might work, but the underlying cause is the B12 or the iron deficiency. So they're kind of masking the headaches. So they work to mask the headaches. And Dr. Shab says, what's MMA stand for? The answer is methyl malonylic acid, which accumulates when you've got chronic or long-standing B12 deficiency. So it's like a toxin. Rupesh says, can you talk to us about self-injection? So self-injection, where I teach you to inject, is quite easy. I think probably hundreds of thousands of people do it in the UK. I've just filmed some videos on it last Friday to make it easier to teach patients. And it would be too difficult to talk about it now. But basically, I show people how to do it. I show them how to draw it up. I showed them how to remove the air from the syringe and the needle, how to select the best place to inject, and where to inject it and how to inject it. So it does take about 20 minutes to show people how to do it. But self-injection, I wish the NHS would do it, because 99.9% of my patients, whether they're 16 or 60 or 90, can learn to self-inject. So really, I would encourage people to self-inject and get free of having to go to appointments for injections and do it yourself, because it's cheap and easy and much better to be in control of it yourself. How important is it to try and find the cause of your B12 deficiency? My GP has given up. Well, you've got to treat the B12 deficiency. That's the most important thing, because if treatment makes you feel better, makes the symptoms go away. So the number one most important thing is to treat it. The number two most important thing is to look for the cause, so you can understand what it is that's causing it and try and remedy the cause, so that maybe you could come off the B12 injections. So I have found that about 1,000 out of 1,000 patients, about 200 have autoimmune disease, so 20%. And the other 800 have primary gut dysbiosis, where the stomach doesn't work for one of 100 reasons. So the autoimmune disease means that you're on B12 injections for life. So that can be true pernicious anemia, where you have autoantibodies in your stomach, but it could be rheumatoid disease, like I mentioned earlier. It could be hypothyroidism, Graves' disease. It could be lupus or Sjogren's. There's 37 different autoimmune conditions, and they all cause B12 deficiency because they attack the stomach. So even just having low thyroid levels and thyroid antibodies causes B12 deficiency in some people because it stops you absorbing B12. So that's 20 out of 100. The other 80 out of 100 is either there's not enough B12 in their diet or they don't absorb it. So it could be that they have too many bad bacteria in their stomach, not enough good bacteria. So that's the microbiome that's been damaged, not enough acid, too much acid, taking PPIs, omeprazole, lansoprazole, taking metformin, all sorts of causes. So I always go into the causes with my patients and look for the causes as well as the effect. So B12 injections are treating the symptoms, and you've got to look for the cause. Hugo says, B12 deficiency support would be delighted to share your training videos. Yes, I'll be happy to do that, Hugo. Once I've had them captioned and edited and so on, I'll be delighted to do that. Your GP has given up. Yes, the GPs often give up because it's too difficult. The best person to help you find the cause if you don't have autoimmune disease is a nutritionist, I've found. So I look for the autoimmune disease, and then nutritionists. So nutrition is a fantastic science, which is people now study at master's and PhD level, and they look at your stomach in terms of acid. They look at your wee and your poo, and they test it, and they look at for nutritional ingredients that you're sensitive to it. They look for bacterial overgrowth, fungal overgrowth. And they look at the cause in your stomach and why you're not absorbing it. So many times, if I can't find the cause, I send patients to a nutritionist to test their poo and their wee and their stomach acid. So very often the nutritionists are the best people to look for the cause. And Charlie says, these doctors are proposing oral cyanocobalamin, all waste of time. If you don't absorb B12, you're not going to absorb oral cyanocobalamin or spray B12. So it's a waste of time. And then testing it again is a waste of time because your blood test would have gone up, even though it's not working. So taking oral B12 when you have neurological symptoms doesn't work, I'm afraid. It has to be injections. And doing the test once you've started oral B12 is just a cop-out because the test levels will go up, but your symptoms won't get better. Paige says, levels of gastritis for stomach. How do you help that get that back on track? Well, that's nutrition. So that's looking at food ingredients that cause overproduction of acid and removing those from your diet, and maybe treating H. pylori or other infections that you've got in your stomach. And if you've got autoimmune disease, it's getting on top of the autoimmune disease. So really it depends on what's causing the gastritis and looking at a nutritional. So it's called healing the microbiome. So it might be that you need to take probiotics. It might be that you need to treat H. pylori or other infections or fungal infections. It really depends on what's the cause of that gastritis, Paige. Why does oral iron give those symptoms? Very easy. If you don't absorb oral iron, then it goes through your bowel and causes constipation, all those side effects because you don't absorb it properly. So many people who struggle absorbing iron get those side effects. And basically, oral iron is a rubbish drug that doesn't work very well and doesn't absorb very much. And that's the problem. So a lot of people struggle with it. But if you take one small dose of oral iron every other day on an empty stomach with a glass of orange juice, which provides vitamin C, it helps the oral iron be absorbed. So one small tablet, 20 to 25 milligrams, every other day with a glass of orange juice or cranberry juice or something that's acidic, that it helps it be absorbed. Lawrence Island says, why are testing lab continuing to have very low and differing reference ages? Well, it's about normal ranges and optimal ranges, Lawrence. I'm interested in optimal ranges, so what works? Whereas the labs are interested in normal ranges, and they're based on 95% of the population. So they test 1,000 patients, and they look at what 95% of the population have. So if they say the range is between 160 and 800 for B12, that's because 95% of the people that they've tested have a range between 200 and 800, okay? That's all they're doing, is they're testing the range in the population. Well, I'm looking at the optimal range, so what works? And what works is more than 450. And in many places in the world, they go on optimal ranges. And so Japan, they treat B12 if it's less than 400. In France and Germany and Europe, they treat B12 if it's less than 300. And I treat B12 if it's less than 300. So the optimal range is at least 300. But in some people, even 400 isn't enough. And even 500 is enough. So it really depends on the symptoms and not necessarily the blood test on its own. So it's the difference between optimum for that patient and their symptoms and the normal range, which is 95% of the population. So if you're trying to save money, you only treat the 5% of the population that, or the 2.5% that have the very lowest range. And therefore, you only treat the patients that have the lowest range. And then everybody else gets left in limbo. Emma says, yes, iron, vitamin D, etc., all above there. So Emma, keep going. You can't have too much B12 every other day and keep going. Elaine says, can you please repeat the ideal ranges? So yes, folate 15 to 20. Vitamin D 75 to 100. And ferritin more than 50. Even better, more than 75. Rachel says, how do you get an MMA test? If your GP doesn't do it, then ask your GP. They probably won't do it because they don't want to pay the £90. So then you could go to a private hospital or go to a private health blood test provider. Medichecks do it. Superdrug do it. You could go to Superdrug and get a blood test and get your MMA and active B12 tested. And I think Superdrug charge £200 for MMA and active B12. So Superdrug are about the most advanced of all the chemists because they know that B12 blood test doesn't work and they'll test your MMA for you. So if your GP won't do it, look online, Medichecks, Superdrug, all these other people. Homer says, Doctors Chandy and Minnie report blood folate levels tend to rise of their own accord when B12 deficiency is resolved. Well, yes, because you start to absorb better when your stomach works better. So the blood levels rise and you need less and less supplementation. So what I find is that when we've cured the bacterial overgrowth that caused the B12 deficiency in the first place, then the folate and the B12 levels rise of their own accord and you don't need the injections and the B12 and the B9. So when does this not happen? When you're still not absorbing, Homer. So either you've still got the stomach problem that you had in the first place, or you've got autoimmune disease. So when your stomach starts to work, the levels rise of their own accord. Sue says, can PA cause by depression? Yes, it can. It doesn't mean it does, because there are other causes of depression, Sue, but pernicious anemia or B12 deficiency on its own can cause depression. You self-inject 3 times a week, and you've got perfect vitamin D, folate, and iron levels, so keep going. And it is really annoying that some people don't get better and do tend to take a long time to get better, but everyone is different. That's the frustrating thing, is there's no one-size-fits-all answer. And if I tell you there's no one-size-fits-all answer, you would absolutely agree with me, because I'm sure you hear about this. Some people need 3 times a week, some people 5 times a week, some people once a fortnight or once a month. You are all so different. Mary says, do I need to avoid analogs, spirulina, nutritional yeast? Yes. The analogs can make your inactive B12 go up and make your active B12 not work. So we think they're not good for you. My doctor and hematologist would not provide an iron infusion. Correct. They usually don't want to because it's too expensive. Ferritin was 17. The NHS normally rations an iron infusion until your ferritin's less than 10. And in some hospitals, less than 8. So they're really only giving it to the worst of the worst of the worst. It's now 57. Good. So it's better, but keep going. Get it up higher. I take B12s every 3 months and daily levothyroxine. Transferrin saturation has got up from, so your iron levels are going up, but you might need more B12 than that depending on your symptoms. So remember, you can have as much B12 as you like. It depends on symptom control. Okay, Kathy, this is a really important point. I need you all to forget about intrinsic factor antibody test. It's a useless test. It only diagnosed out of my 2,000 patients. I've only had a positive intrinsic factor antibody test in 2 patients. It very rarely comes up as positive. It's the least useful test I do, yet all the GPs do it. So please ignore it. It's only the worst of the worst autoimmune patients have intrinsic factor antibodies. So GPs use it as a way of not giving out B12 to the other 998 patients out of 1,000. So intrinsic factor antibody test is absolutely useless. Much better is gastric parietal cell antibodies and ANA antibodies and thyroglobulin antibodies and thyroid peroxidase antibodies. Intrinsic factor is the most useless tests of all the ones we've talked about today. So just ignore it. So GPs are reluctant to give out B12 because it's expensive and because they don't have many nurse appointments. So if they get your nurse to inject you with B12, they're using up their valuable appointments, which cost money. So do it yourself. Get somebody to teach you to inject B12 yourself because your GP is not going to give you enough. Finger prick homocysteine test is available on foodforthebrain.org. I'd love to see how accurate it was and how it works because that's very interesting. If cofactors are optimal, says Catherine, and multiple everyday injections are enabling accelerated improvements, but the frequency of injections is becoming shorter, I would just keep going with every day, Catherine. I only know of really 1 or 2 people that go them more than once every day. So I wouldn't go them more than once every day. The problem is that you really use up your iron, folate, and vitamin D too quickly. You burn through it. So every day is just the most I would do. And actually, I find every other day may be better because it allows you to replenish your stocks of the folate and vitamin D and iron for your enzyme reactions. So I tend to prefer every other day than every day just for effectiveness. Where does magnesium figure, says Mary Breen? Well, magnesium is one of the cofactors along with zinc and selenium, and you need a little bit of magnesium, a little tinsy-wincy bit. So I don't know how much, but a little bit. And a bag of nuts once a week, if you can eat nuts, gives you enough zinc and selenium and magnesium. So it's a little bag of £1 nuts from Tesco, mixed nuts. So Brazil nuts is particularly good for selenium, and walnuts are particularly good for zinc. So a little bit of magnesium, please, but not too much. What's the reason for adding B9 to flour? We'll have to speak to the government health advisors about that. We have written and said, don't do it. And please, because it's going to make testing for B12 impossible. But they're worried about neural tube defects in pregnant women. So to prevent that, they want to give everybody extra folic acid in flour. I think it's crazy. But I don't work for the government. Hugo says a multivitamin. Yes, Hugo, maybe, but multivitamins have got a lot of other stuff in it that you don't necessarily need when you're having B12 deficiency. So I'm not so sure about multivitamins. I will disagree with you on that one, and we can argue it another time. But they've got a lot of other stuff that may not be too good for you, and I don't like them because you can get too much B6, B3, B2, and other things. So I prefer to take the individual ones rather than multivitamins, but that's just me. Is blood volume? No, we've talked about blood volume. My ferritin is 700. Well, that may be an inaccurate reading, Mary. I would do your iron panel or ask them to do an iron panel and look at the transferrin saturation. And you only need to worry if your transferrin saturation is over 40%. So ferritin can be inaccurate in people with arthritis and inflammation and a lot of other things. So if your ferritin is high, ask your GP to do an iron panel, and transferrin saturation more than 45% is all you need to worry about. Do we need to avoid folic acid fortified foods? Well, probably not if you don't have any problems with folic acid. But if you, and generally speaking, as I said, you can't have too much folic acid generally. But the problem is if you're testing for B12, you need to avoid folic acid fortified foods because it makes the test inaccurate. So really, it's about testing versus not testing. Susan says, thank you, Andrew. Now I know you weren't imagining things. Mary says, video link, please. No problem. Okay. Julie, classic. Parietal cell antibodies are positive. Yes, you have B12 deficiency. You have pernicious anemia, 100%. Absolutely no doubt, Julia. And that means you have autoimmune atrophic gastritis, where the parietal cell antibodies attack the lining of your stomach and cause autoimmune gastritis and cause B12 deficiency and iron deficiency and folate deficiency. So you need B12 for life. So that's the classic form, and that's a classic thing. That's why the intrinsic factor antibody test is negative. So even in someone with classic autoimmune pernicious anemia, the intrinsic factor antibody doesn't help. So the test I really love is the parietal cell antibody, because it picks out the worst B12 deficiency, I'm afraid. You need the most B12 because you will never absorb any B12 from your diet, whatever you do. So you need lots of injections until you're better. Every other day injections until you're better. And you're probably going to need sort of once a week for life, even when you're better. So parietal cell antibodies mean you've got classic pernicious anemia, autoimmune gastritis. Are natural B12 forms better than the cyano form? Everything natural is better than the supplement form because supplements are artificial chemicals. So yes, there's no doubt that natural B12s from the animals and fish from the soil are better. So grazing on grass and eating lamb is the best form of getting B12 from animals. Fish that are wild that we catch and we eat then have the best form of vitamin B12. Milk and cheese from cows that graze on grass naturally is the best, and so is sheep's milk is even better, and sheep's cheese. So natural anything, natural magnesium, natural B12, natural iron is always much better than supplements, which are generally rubbish because we're not very good at making things that are pure and that work very well. So that's why if you can heal your stomach and you absorb it naturally, it's always better than supplements. So that's why nutrition is key, to heal your stomach and absorb naturally. I hope that answers that, Homer. I have ground my teeth to the extreme. Is this common? I don't know. It is common. I do it myself, but I'm not sure it's common with B12 deficiency. I just think it's one of those things that people do, and you have to wear a retainer to stop yourself grinding your teeth to the bone. It's a horrible thing, and I hate it. Is magnesium an important cofactor? Yes, all the cofactors are important, but not as much as iron, vitamin D, and folic acid. How much vitamin D is necessary? Lots to get your vitamin D up to 75 to 100. So I normally say vitamin D3 with K2 is the best because the K2 helps you absorb it, and you need about 3,000 or 4,000 units a day to keep your vitamin D levels up. That's 3,000 or 4,000 units a day. You can get that over the counter in all good chemists, online or Superdrug or Boots or Holland and Barrett. Is gentle iron any good? Well, all artificial iron supplements are bad, but gentle iron is probably better than any of them. 20 to 25 milligrams once every other day with a glass of orange juice. I must be wearing out all your questions. You've got 1 more minute left. Anjali, what if folate is very high and so if serum B12 as you had an injection? So serum B12 you ignore when you're having injections. Ignore. It means nothing. Doesn't matter. B12 is high, then cut down the folic acid that you're having. You want to keep it 15 to 20. So if you're having folic acid twice a week, go to once a week. If you're having once a week, go to once every 2 weeks or take a lower dose. So you just want to let the folic acid fall, the folate fall to 15 to 20, Anjali. Rupesh says, opt to a range B12, we can treat anyone coming to general practice with tired all the time. Well, I would say 9 out of 10 patients come into general practice would have a B12 of 450. And I'm not talking about tired all the time. I'm talking about the neurological symptoms. So I would treat somebody with numbness, pins and needles, tingling and brain fog with B12, regardless of the blood test. But I wouldn't treat someone just with tired all the time symptoms. That's the key. It's looking for those neurological symptoms that go with it. They are the key. Okay, I think we've run out of time, Hugo. There's still more questions. And I'm happy if you want to copy and paste them. Someone says, what's the accuracy of a parietal cell antibody test? 100%. If you've got it, you're 100% if you've got autoimmune B12 deficiency. To test gastric parietal cells, do you need to stop B12? No. Worth taking other forms? No, just hydroxycobalamin. Is it safe to take potassium supplements? No. It's very difficult to take potassium supplements. D3 and K2. It's just lots of fantastic questions. So I really appreciate all your questions, and I hope I've answered as many of them as I can. I hope it's been useful.
So I don't know if you're able to carry on talking. The people in the audience are likely to stay on for 90 minutes till past. because the invitation was for 90 minutes. But that doesn't mean that you've got time, because you've had a busy day today.
I do have to go. I have to have my dinner.
Yes, absolutely. I used to say this. My campaign for GPs when I was running a federation was that GPs would spend Sunday afternoons at home with their families.
Yes, and I have to have my dinner, so I will apologise, everybody, and go and have my dinner.
We will
I hope it's been useful, and I'll be happy
yes.
to come back and answer questions another time. And
yes.
the questions are the best bit, or the Q&A is the best bit, questions and answers, because there is so much. It's a very simple condition, but it's a very complicated condition. So it's very simple. The treatment of B12 deficiency is B12. But
yes.
it's complicated because the cofactors are complicated, the causes are complicated. Very few people understand all the nuances. There's lots in the literature, but it is complicated. So I think it's very easy, but very complicated. Rachel says, "Oh, hello, Rachel. Nice to hear from you. Enjoy your dinner. I'm successfully self-injecting thanks to your brilliant lesson in April." Rachel, it's a pleasure. And I hope you're feeling better. And Catherine says, "Thank you for so much clear information." There is so much information, and it's a complicated but simple thing. So once you know and you get the hang of it and you get better, it's fantastically simple. And when you're struggling, it's fantastically complicated. So any help that I can give people, I'm delighted to do it. And I'm happy to share my videos. I'm happy to answer questions, and happy to see you if you need an iron infusion or if you want a one-to-one. You can look me up on Google and read about what people have said when they've come and seen me. So it's fantastically simple if you're doing well, but if it's complicated, I'm happy to help if I can.
Yes, we've been absolutely delighted with the talk this evening. It's been extremely interesting, particularly as you say, there's been so many questions, and they're really good questions. What we will do is copy all the questions and forward them to you anyway.
Perfect.
If you find that you've got a sleepless night or something and want to record some answers, just record them. No need to write them, just record them.
No problem, I'll do that. And it's very nice. I see some faces I recognise as well, some names I recognise. So it's really nice to see some of you. Just a plug for the TLC Long COVID podcast. So the TLC are the Long COVID ladies. And if you look up TLC Long COVID podcast, I did one on long COVID and B12 and iron deficiency. And these two ladies have been fantastic about looking at disinformation about long COVID. So if you want to listen about long COVID and B12 and iron deficiency, if you look up TLC Long COVID podcast, they're very, very well done podcasts, and I can highly recommend them. And again, that's people doing it for free to help other people. So they're patients with long COVID looking to help other patients, which generally means that they're honest and fair, because they're just trying to help people, much like you guys in your group.
Excellent. It's been an absolute delight, and of course we will love to invite you back. We're trying to say come back in 6 months, but you may be feeling bruised after today. And
no, I'm not bruised. That was lovely.
We'll be delighted to have you back in 6 months. It's thank you very much for everything you've done, and for being one of the instrumental components, one of the pillars that holds up Club B12 as well.
It's a pleasure. What makes me happy is seeing people better. So when I see people better, and Rachel's smiling, I now can see she's turned her video on, then that's what makes me happy.
Excellent. Thank you.